So we were talking about initial diagnosis, and then I was moving to management of common health problems. So, so feeding problems. When I've talked to families who have kids who have Wolf-Hirschhorn, pretty much everybody reports some level of feeding difficulty at some point. And a lot of the patients, it's severe enough that either tube feeding is pursued or recommended by somebody. And so that's a decent piece of people's experience with feeding. And then, of course, if cleft lip or palate is present, that drags down the feeding additionally. And there's a lot of feeding considerations with individuals with cleft lip and palate. And then there's also a component of hypotonia. So the facial muscles are weak, and the facial muscles are really important, particularly for bottle feeding and nursing or breastfeeding. Facial weakness doesn't always impact feeding quite as much later, but very early on in life, facial weakness is a huge component of feeding problems. And then there's also feeding skills issues. A lot of the patients have sort of skill-related feeding issues. And when I just talk and communicate with families, I get a lot of reports of even older teenager and adult patients who still really prefer and primarily eat pureed food. And that's something that I just came across a lot. And so there definitely are a lot of the kids, even if they orally feed, they need their feeding method adapted for their needs. And so this is a big important issue. We do have some morbidity related to feeding. A lot of the kids who have a little bit more neurological impacts are at risk for aspiration. And of course, there's several pieces to aspiration. Some of the kids actually have airway, like mechanical airway problems, or even anatomic problems in their airway. And then a lot of the kids really reflux a lot, and that can predispose to aspiration. And then there is the immune piece. So recurrent lung infections are reported a lot by our patients' families, and the immune piece probably plays in that too. So when they do aspirate, the risk of getting a lung infection from that is probably a little bit higher, although we don't know exactly. Another problem that a lot of parents have reported to me are gut motility issues. And so when you're feeding the kid, the comfort that the child has with feeding, because the food needs to move from the mouth all the way through and out the other end. And if there's any problems with motility, then there's more discomfort and difficulty feeding. And of course, as physicians, we have no good strategy really for managing gut motility. There's some medications that can be tried. I find that they tend not to work very well or work over long term. And so most of the way we manage motility is with different feeding strategies: feeding slowly, tube feeding, feeding jejunally. And of course, none of these are real great solutions, and it tends to be an ongoing issue. I put malrotation in here. Malrotation and atresia are both seen. Whoops, I don't have atresia mentioned. Malrotation and atresia so that's when the gastrointestinal tract's not all hooked up with itself. There's a blockage somewhere that's congenital. They were born that way. Can happen. And then also I've seen malrotation personally. So that means the gut is not hooked into the abdomen properly, and it can twist and kind of cut itself off. And it can both prevent food from moving through, and it can also cut off the blood supply if it's really bad, which of course can be catastrophic. And that's a birth defect. It's present. It's the way that the gut formed itself before the baby was born. And so anytime that we're seeing really persistent vomiting, we need to think about a birth defect of the gastrointestinal tract. And sometimes we forget to consider that too. So there's all these components to the feeding problems. And I think every kid with Wolf-Hirschhorn has a little bit different components that are involved in their feeding problems. And so feeding can be really challenging. And of course, feeding is one of the first things you do with your child after they're born. And so if there are feeding problems, it's instantly frustrating. So management of feeding. So at this point, I don't know anyone who routinely does a swallow study on every patient, but you should have a low threshold. So if you're concerned about how the baby's eating, and a swallow study is what we call the study that we do in the U.S., what we call the study looking for aspiration, to see if we're swallowing properly and make sure it's going in the stomach and not the lungs. And I would say if there's any worry, just do the study and see if eating is safe. the standard of care is to have a formal speech and feeding assessment at diagnosis by someone who's good at that. And in the U.S., the feeding specialists and the speech specialists are kind of the same people, so that's why I say speech and feeding. And then a lot of kids have reflux. We don't manage reflux differently if you have Wolf-Hirschhorn than if you have significant reflux and you don't have Wolf-Hirschhorn. Same medications, positioning strategies. And a lot of the kids, at least in the U.S., have had Nissen fundoplication. And I see that tends to kind of be a decision made by their gastroenterologist whether they would pursue surgical management of reflux, but certainly been done plenty. And then it's good to have a nutritionist involved if you can get one. Sometimes in the U.S., it's sometimes really hard to get a good pediatric nutritionist because of depending on where you live. And then I talked a little bit about tube feeding. Some patients do need tube feeding depending on if there's aspiration, of course, because that can protect if you're inhaling food. Tube feeding is a really good strategy for avoiding inhaling food. But then some of our patients just have enough trouble eating by mouth that they may need a G-tube. And then because of the risk for malrotation, low threshold for imaging the gastrointestinal tract to make sure there's not a birth defect somewhere in the GI tract. Another really common health problem, growth. Really, everybody with Wolf-Hirschhorn is small. If you're not small, I would wonder if you really have growth Wolf-Hirschhorn because it's just part of the disorder. And all dimensions of the person are small. So the head's small, they're short, and their weight is low. There's different disorders, of course, you can have just part of that. But in Wolf-Hirschhorn, you're small everywhere. And one of the big problems that I run into with other providers is other providers seem to think, because there are feeding problems, they always seem to think that this is an issue of inadequate calories. And if I can just get more food in this kid, they'll grow. And it's just not true. You can put a lot of food in, and there are a few patients who are fat because we've overfed them, but it doesn't make them truly bigger. There are a few patients who are fat because we've over-tube fed them so much that we just made them fat. Although a lot of the kids are not fat, even if you feed them twice or three times as much calories as you would think they would need based on those routine calculations. So we often put too much pressure on the growth because this is a disorder at baseline where people do not grow well. Your body is designed to not be big when you have Wolf-Hirschhorn. And so you want to monitor it, but you don't want to flog it too hard. It's really common for bone age to be delayed, and that's sort of part of the growth. Of course, when I'm talking about not killing ourselves over the growth because it's normal for a person with Wolf-Hirschhorn to be small, that's normal for them. That being said, there are some patients who have growth hormone deficiency, so it is reasonable to evaluate that. And this is one of the reasons that we need growth charts, because how you tell if somebody is needing to have their growth hormone checked is if they're falling off their growth chart, which is why we need Wolf-Hirschhorn specific growth charts, because otherwise they're not as big as somebody who has all of their 4P. They're just not. And so using a typically developing kid's growth chart is useless. But on the other hand, we do know there's some risk for growth hormone deficiency, so it's nice to be able to monitor the growth. At this point, you were kind of in a tough spot because the growth charts only go through age 4. So as far as management of growth, good measurements. And it's good to make sure that at least you can check the velocity of growth. So how fast is the person growing? Because they should be growing. If we're not growing at all, that would be really concerning. And so you want to measure everything and plot it. And then there are Wolf-Hirschhorn growth charts available for people through age 4. We're working really hard on trying to stretch that out to 18. Hopefully we'll get something soon. I've been saying that for years, like 5 years, but we're still working on it. And then, like I was just discussing, pretty low threshold for evaluating growth hormone itself. And then this is really, really important. A lot of my parents of patients that I've met and taken care of, have really felt punished by their healthcare providers for their child's growth. And it's really, really important to not make families feel that the child's poor growth is their fault in any fashion, because it's not, it's part of the disorder. And it's because of their chromosome deletion, not because of what the parents are doing to feed them. And this has just been a big issue. Okay, another major health problem associated is neurodevelopment. even though some of our patients have normal intelligence, not very many, but there definitely are some, everybody has some impact on their neurodevelopment, and everybody has some difference in their neurodevelopment from a typically developing child. And so it's there. And a lot of patients have significant impacts. So this is, of course, this is from a relatively recent review by Dr. Battaglia. That being said, the literature always skews negative compared to my experience, but of course I don't have any formal documentation of that. So when you look at the literature, they say about 65% of kids with Wolf-Hirschhorn have severely impacted development, and about 35% have mild or moderate developmental impacts. And of course, that depends on how you define some of these things. The interesting thing is, if you look at their ability to socialize and communicate in a social setting, and then if you look at sort of formal IQ, their school performance tends to be a little bit worse than both of those things. And I think there's an attention/executive functioning piece there. And a lot of my higher functioning patients have ADHD or have been formally diagnosed with ADHD. And I think that because, you know, when you have ADHD, you often don't do as well in school as you kind of should, wherever that comes from. And so I think there's a piece of this. So some little specific components of neurodevelopment: speech. Oral speech tends to be challenging, and for some of the same reasons that feeding is challenging, with some of the motor weakness in the face and possible cleft lip and palate, and they have a small jaw and they have a small mouth. And so all of these things with oral speech are just more difficult. And then, of course, there's the neurodevelopmental piece, because speech is very hard from a cognitive perspective. A lot of our patients have single words only, although we do have patients who can speak fluently and talk your ear off. There is an absolute drive to communicate in all of the patients that I've met, including some of the most severely impacted patients that I've met, who have no words. They're with you. They look at you, they're with you. And so there's a clear, and all the parents that I've asked this question of have said, yes, my child wants to communicate. There's a drive to communicate. So I've had people report autism spectrum, and I've had patients who are assigned autism spectrum. But in my experience, of course, when I think about autism spectrum, is your communication is worse than your intellectual function. I think that's sort of a key piece of autism. And there's really a drive to communicate in the patients I met with Wolf-Hirschhorn. So I don't know if I'd assign any of them autism, at least anybody I've met. And, you know, kids with autism are supposed to not use any meaningful gestures. And I have to say, everybody I know with Wolf-Hirschhorn uses some sort of meaningful gesture. And a lot of our patients who are not orally verbal have been very effective using sign and communication software. And so I have lots of patients who can do full sentences and have paragraph conversations with you using a talking board or other electronic communication software. So that's actually been pretty effective for a lot of the patients. I really like everybody to get detailed neuropsych testing so that you have all the different components, not just an IQ. And neuropsych is really looking at, I mean, there is an IQ assessment always as part of it, but also looking at memory, concentration, focus, working memory, long-term memory, all these kinds of different pieces of the neurodevelopmental. And the trouble with this, of course, sometimes it's hard to find somebody who can do this, especially on a kid who's neurodevelopmentally impacted. And so sometimes that's kind of tough. And then other management pieces, everyone should have some sort of early intervention. In the States, that's what we call it when you have a baby who you're worried about their development, and you start in with speech therapy, physical therapy, occupational therapy. The program is referred to as early intervention in the United States. Then everybody should have some sort of an individualized rehab program with feeding therapy, speech therapy, occupational therapy, physical therapy, cognition support, communication support, socialization support. It's really important to think about appropriate school placement. And of course, I didn't want to say a lot about that because that's so different depending what country you live in and where in what country you live in. And so it's hard to say when you aren't familiar with the person's individual situation, but appropriate school placement is critical. And then transitional planning is also critical as part of the management of neurodevelopment, because most of our adults are going to need support as an adult, because even our highest functioning patients tend to need some level of support as adults. And a lot of the patients will need quite a bit, depending on of course, this is going to be highly dependent on level of cognitive function. Another really important area of medical problems and management is seizures. Even though seizures are a really important piece of Wolf-Hirschhorn and are part of the diagnostic criteria, they're quite variable from patient to patient. And I think we've had every single seizure type, pretty much. Even things I'd never heard of until the parent reported it to me because I'm not a neurologist. And so I really can't find that there's a seizure type that we see. I mean, there are some that are more common. Most patients have recurrent seizures, which is what epilepsy is. Sometimes people ask me, well, but my child doesn't have epilepsy, right? Usually we define epilepsy and seizure disorder are essentially the same thing. Anyone with recurrent seizures can be said to have epilepsy. And this 95% is what I found in several review articles. It's low. I think it's a little lower actually in the support group population, but it's still most of the kids. It's still vast majority of the kids. And there is a significant risk for prolonged uncontrolled seizures, or what we call status epilepticus. And this is a really scary thing that can happen. And then and like I talked about a little bit earlier, there's a remitting course. So kids start having seizures usually in the first year of life, and then they'll often go away, and then they'll come back again in adulthood. We do see developmental brain anomalies, so the brain is smaller. Sometimes we see abnormal location of gray matter, so it's called heterotopia. And then another not as common thing we've seen is this part of the brain that does sense of smell can be small. The most common thing you see if you do an MRI on a kid with Wolf-Hirschhorn is just hypoplasia of the corpus callosum. Most kids actually have a quite normal neuroimaging. And then almost everybody has a small head. And then another piece of the neurological findings is low muscle tone. And this starts before birth. A lot of my moms report that the baby did not kick as much as other children if they've had other children, so they have something to compare about. And this is central because when you're looking at someone who has low muscle tone, you wonder if it's the brain telling the muscles to have tone or if it's that the muscles are weak themselves. And this is central. So they don't, and people have looked at this. So people have biopsied muscles and studied muscles and done EMGs, and those are all normal. So if you look at the muscles, the actual pieces of the muscle with people with Wolf-Hirschhorn, their muscle is normal. So the tone issues are related to the brain telling the muscles to have tone. So management recommendations for our neurological problems that we see. Again, the video EEG, Dr. Battaglia is really big on this. And of course, he's a neurologist. So he's, besides being one of the #1 experts in Wolf-Hirschhorn in the world, he's also a neurologist. So he's always my go-to for all the neurological stuff. And he says, again, at diagnosis, like I said earlier, you need the long video EEG. And then it's very important to follow it up at regular intervals and make sure that you're getting good management of seizures and you're not missing subclinical seizures. There's some preliminary evidence that suppressing abnormal baseline EEG is helpful. And then pretty much everybody needs a seizure doctor. The recommendation is a low threshold for neuroimaging, although a lot of times we don't find actionable stuff all that often. And most patients need anti-seizure medications. And so that's another reason why you need a seizure doctor, because pretty much only seizure doctors are really comfortable managing those to the level they're going to need. And a little bit more about seizure medications. I keep bringing up Dr. Battaglia. He's the go-to on this. So I got this from him. So he recommends, if you're seeing status epilepticus, which is seizures that will not stop, is intravenous benzodiazepines. And that's the standard of care for status in the U.S. So this isn't a big difference. If you bring your child to the emergency room because they're having status, this is what they're likely to do anyway. So this is not a huge management change from other kids with status. And then secondarily adding phenytoin. That's actually pretty typical status management. So he doesn't recommend a change from what we would normally do. If you're seen as if one of your seizure types is an atypical absence, Dr. Battaglia says what he finds most effective is valproate. And then he recommends for tonic-clonic seizures, phenobarb, I think that's a practice issue with Italy particularly. We tend to stay away from phenobarb in the States. We almost always use levetiracetam, which is, and I spelled it wrong there, rats, which is Keppra is the trade name. That's what we usually use in the States for management of tonic-clonic seizures. Another big issue, congenital anomalies, particularly congenital heart disease. It's relatively common, and we can get severe heart disease, but that is not usually what we see. We usually see pretty straightforward congenital heart disease, and it's repairable. And so I would recommend, and every once in a while I have an awkward conversation with a colleague who's not in genetics who thinks we should not repair the heart disease. And I would always recommend repairing it if it's something that needs repaired, that you would repair in another child. I would always recommend repairing it. This can be a cause of morbidity for kiddos with Wolf-Hirschhorn. So kidney problems. We are finding that kidney problems are more, this is sort of a relatively recent piece of our understanding of Wolf-Hirschhorn. You can absolutely have congenital anomalies of the kidneys. There have been a few patients who have had no kidneys. More common is very small kidneys. We've had a couple of patients born in complete kidney failure from birth. Although that's not common, you can see it. You can get malformed kidneys, all types, the kidneys that are fused together, kidneys that are in slightly wrong spot. And there's always a risk for abnormal function, even if the kidneys look okay on imaging. And then, of course, there's the possibility for reflux, which is where the urine goes back up into the kidneys, which can increase your risk for infections. Okay. And then ears and hearing. The ears are usually a little bit different in appearance from other kids. They have small ears. They have a few less curves in them. And then hearing loss is really common. And I talked about hearing loss earlier, so I'm not going to go into a little bit more right now. And then with the eyes, you can have congenital malformations. Coloboma is when the iris hasn't formed completely, or when the optic nerve hasn't formed completely in the back of the eye, and those can both happen. Glaucoma is when you get more pressure inside the eye. That's really important to monitor. And then ptosis is when the eyelids are a little droopy. That tends to not need any particular management. But then we were talking about immune system earlier. We don't have a lot of data. We suspect this is a problem, but we don't have a lot of great data, so it's harder to make recommendations for what you should do. A lot of our patients, if they've had their antibodies carefully measured, you do find they're abnormal. A lot of patients haven't had this done. And we don't have any data on what the incidence is. We've also seen patients who have T-cell problems as well. What we do know is that most families report more infections than their other kids. So more ear infections in particular, more lung infections, more colds, getting sicker than their siblings when they do have an infection. And there's just really, the thing is, there's really been no systematic study. So it's really hard to give you a good data and recommendation. And then sort of in this group, we definitely have seen bone marrow dysfunction and failure. And I have no idea how common it is or whether this is something we need to be keeping a super close eye on. And then, of course, we've also been getting, really this is just verbal reports to me from parents of premature aging. That's just coming up from the support group. So specifically early graying, early wrinkling. There was a concern that maybe there was premature ovarian failure at one of our older women. But, you know, it's just sort of a impression that I get from talking to people. So, specific recommendations for routine health maintenance. Dr. Battaglia suggests that everybody get regular video EEG monitoring. He really likes prolonged video EEG monitoring, not just the 30-minute routine EEG. That is what I usually get in the States from my patients. And then, and of course, the interval there should be based on how the kid is doing. So depending how their seizures are, how your seizure control is, you know, if it's been 5 years since they've had a seizure and they aren't on any medicine, you probably don't need to do one. Whereas if you're having ongoing seizures, it's good to keep monitoring it. Most people recommend that we do at least once a year check a full blood count to make sure that the bone marrow is working properly. I don't actually know how many patients we're going to find with bone marrow failure, but this is a relatively straightforward thing to check. And so we do know we need to do annual renal function testing, and we should do really probably all of these pieces. So at minimum, we got to be doing a blood kidney panel, checking BUN creatinine, creatinine clearance, which you can usually calculate from that routine kidney panel. And a lot of our experts, I usually get a cystatin C as well, which is another marker of renal function. I like to get a urinalysis, particularly look for protein to see if we're getting excessive protein in the urine. And then depending, it's reasonable. I usually get a yearly renal ultrasound as well on my patients. And so that's really, most of us do this detailed kidney monitoring because we know that we've had patients progress to renal failure. And so so I've kind of these top things are things that I always do for all of my patients. We're now wondering if we should be doing some level of routine liver monitoring. That's still up in the air. So if we really do have some sort of predisposition to liver cancer, other disorders do it as often as every 6 months, liver ultrasounds, but I don't know the risks are high enough that we need to do that much imaging. I do like having a baseline of people so that if there's a concern, you have something to compare it to. And then Dr. Botelli says do not use carbamazepine. So, because it actually can worsen things. Again, a little bit more routine health maintenance and prevention of complications. So as far as the neurodevelopment, we really want to focus on making sure you have ongoing comprehensive rehabilitation plan. And then we want to make sure we're still following the hearing, because the hearing loss can occur over time. It can be present from birth, or it can occur over time. With the immune deficiency, what I usually do is, if I'm concerned, if I'm getting a history of a lot of infections, I'll have an immunologist help me decide what to do about managing that. We do have a few patients who are on IVIG. We have a few patients who are on prophylactic antibiotics, so antibiotics as a preventative. Not very many, so I don't know how many people actually need it, and we just don't have any data. Of course, I keep saying that, but it's true. And then with the kidney failure, we have now seen a bunch of patients, and I think this is really a real problem. It's late childhood and early adulthood, so teenagers. And we have had several patients who needed a kidney transplant. And kidney transplant has been really well tolerated. It's gone just fine. So this gives us, of course, a really good reason to monitor this, because, of course, if somebody's going to kidney failure, you can do dialysis, but we can also transplant them. So this is something that's treatable, and we need to be really proactive about it. And so this is kind of in the last 5 years, this is the big piece of medical management for Wolf-Hirschhorn that we've added in, because we always knew about the seizures, the developmental, and the feeding and the growth. But now we know that we need to monitor the kidneys as well. And this is something, especially as you're getting a little bit older and adults, that we know. And then a little bit about additional preventative care. I don't know about the cancer piece, because we just don't know how real that is right now. And so different, Dr. Botelli and Dr. Carey and some of the other experts are sort of vacillating what we should be doing about this. I would suggest that we minimize radiation exposure, because that's a relatively easy thing to do. And then also sunscreen. And another piece that we need to be thinking about as patients get older is that the seizures have been documented to come back. So kids who've had a lot of seizures in early life, if they've gone away, they absolutely can come back. So we need to be aware of that. Although I don't think any of our parents are just ignoring this. It's gone, it's never coming back. But it's still something we need to be aware of. And then we're starting to get a feeling that there's premature aging. And we've definitely seen premature graying. And then some of the parents have reported. And of course, we don't have good enough data on adults for numbers, but I have parents reporting premature menopause too. And so between this and the potential cancer risk, sun protection is really critical. And also, I did find, as I just went through the 4P16 band and looked at every single gene. which is a lot of genes. And there is a gene for UV radiation sensitivity on 4P, and it's included in a lot of deletions. And so our kiddos are probably excessively sensitive to UV radiation. So sun exposure is actually probably really important, and we probably don't talk. So sunscreen, wearing a hat, not going out too long, all the sorts of things that those of us who are maybe a little predisposed to skin cancer should be doing anyway. And the big one, lifespan and causes of mortality, this is the number one question that parents ask me, will this kill my child? When will this kill my child? What part of this will kill my child? This is a really, 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 really hard question to answer. Really hard. And I could not find any good systematic data. It isn't heart disease, which is if you ask a random geneticist or random pediatrician on the street, if they've heard of Wolf-Hirschhorn, they will tell you it's the heart disease. Although we do have kids who pass away from their congenital heart disease, usually the congenital heart disease that we see in most kids with Wolf-Hirschhorn isn't significant enough to really contribute as the primary cause of death. I do know that status epilepticus is a big piece for the patients that I've known that have passed away. So not being able to stop seizures is a big piece. So being careful about seizures, having a plan for when intractable seizures happen is a really important part of preventing mortality. We've certainly had patients aspirate, so breathe in food while they're eating and have pneumonia and then pass away from pneumonia. And infections have been a piece for some of our kids. Again, exactly what and when and how and all those pieces are really not available. And then we certainly have had patients pass away from cancer. So all of those, but it's hard to know what exactly, and we don't know what the lifespan is. I know that the oldest reported person is 65, and she does have a very large deletion. And of course, one of the reasons we don't know what the maximum life expectancy is because 65 years ago, all we could do was a karyotype. And so you miss a lot of our patients that way, like when I was talking about appropriate diagnosis. So our patients with the smaller deletions, we've only been able to do microarrays for 10 years, maybe tops. And so our cohort of patients, we don't have adults. I mean, they could be around and we just don't know what we could have tons of people in their 60s and 70s running around. We just don't know they have Wolf-Hirschhorn. So it's really hard to know what the exact lifespan is. We do know that this disorder impacts your lifespan because there certainly are complications of the disorder that cause mortality. We lose a few kids every year in the 4P- support group from various things. And so it absolutely does impact your lifespan, but I don't know how much. And I think it's very, because this is such a variable condition, I think it's different for every kid too. And so that's a really hard prediction to make. And I know it's one of the big pieces for parents. So the short summary, every patient is different. We need to be flexible in our management, team multi-specialty care, and we need to avoid loss to follow-up because there are lifespan issues. So specifically with kidneys, early aging, and possible cancer. And hearing. Hearing needs to be monitored lifelong. Okay. Now just a quick review of some of the challenges that parents have told me about. And of course, I've been bringing these up intermittently through all the different talks because it is really important to me what the parents tell me they need. And so, major reported challenges. So most of this information, all of this information is obtained from me talking primarily to the families of people with 4P disorders, either directly like face-to-face or phone or email. And there's sort of three really big areas that are reported as problematic by my families that I've interacted with. That's how I broke them down. That's just so I can be organized. So big issues, particularly, and this is focusing on the United States primarily because that's where I am. Getting a diagnosis in the first place, stigma, education and services. So it is actually sometimes really hard to get the diagnosis made. this is a particular patient story. So she presented with poor growth, extremely poor feeding, serious GI problems. She had bad motility, and she had intractable seizures. She went all over the place, saw many subspecialists. And one of the pediatricians involved in her care actually brought up a diagnosis of Munchausen by proxy, which is inflicted medical care. So it's a type of child abuse in which the parent inflicts medical care on their child, which of course was an absolutely horrifying experience for this mom. And finally, after much muckety-muck, got referred to a medical geneticist and got a microarray and was confirmed to have a 4P deletion. So obviously the mother was not inflicting these problems on the child. So that's a kind of a horrendous example. Here's another example where the diagnosis was not delayed. So prenatal diagnosis, and this very similar has actually happened to me twice. So they were doing a routine ultrasound. In the U.S., everybody gets a detailed ultrasound around 20 weeks of pregnancy. And because they were at a really serious center, the facial gestalt was actually suspected at ultrasound, which just never happens. And then a prenatal, so they did an amniocentesis and were able to actually make the diagnosis by karyotype and amniocentesis. So these are big deletions. And then kind of nothing. So both of these patients were just discharged to home with no feeding plan, really no medical plan, nothing. And both of these patients are alive years later. So they were basically sent home to die and didn't, because most patients with Wolf-Hirschhorn don't die. And then of course they come back in with their baby saying, well, she's not dead. Both of them were girls. Now what do I do? So that's, and of course those are both really bad examples, but pretty much every parent that I've talked to in our support group had a bad experience with their diagnosis, just about. And so, that's a big problem. Okay, so difficulty achieving diagnosis. So lots of parents tell me that nobody was taking them seriously. They knew there was something wrong. The baby wasn't growing right. The baby wasn't eating right. Nobody was paying any attention. And of course, because this is a rare disorder, and you guys know all about this, because this is a rare disorder, it's hard to find somebody who knows anything about it. So there aren't enough, and in the U.S. we have a very bad shortage of geneticists. We're not training enough of them. And so if you need to see a geneticist, you're going to have to wait months and months too. And some of the practices have a year wait in the United States to see a geneticist. And then, of course, because I'm from the U.S., we have insurance problems and coverage problems. So you may not have any health insurance. So you may not be able to see a specialist. If you do see a specialist, you might not be able to get any testing. As recently as 2 years ago, I had to fight for every microarray I ordered. I have to write pages and pages of justification for why we need to do a microarray. So standard of care. Anyway, so this maybe not as much of a problem here, but for me, this is for our group in the United States is a huge issue. Providers are not familiar with this diagnosis. So medical geneticists in the United States are the only physicians trained to recognize this diagnosis. And even geneticists are kind of bad at it a lot of times. So they may not even think of it. Even if you go to a geneticist, you're supposed to know. And then on top of it, all the easily available information is inaccurate. The textbooks are grossly out of date. And most physicians have had, essentially in the United States, have had zero teaching about this. Which is just has a huge impact. So this provider issue impacts patient care because you get pessimistic or dismissive counseling, and then they don't do the preventative care because they don't even know about it. So obviously you can see how that would be a huge issue. And then I think stigma is probably the single most serious issue. Because this is a disorder associated with intellectual disability, there's an incredible amount of stigma, and it's everywhere, all over. And worldwide, intellectually disabled individuals are persecuted. And a lot of my patients tell stories about not being able to do normal things because people are being prejudicial, bullying, staring, picking on them. And it's just incredibly hard. And healthcare providers participate in stigma. And this is just a huge problem with my colleagues in the U.S. And almost every one of my patients has given me an example of provider-based stigma, which I think is unacceptable. Not that we should be having stigma in our population either, but providers should not be participating in making people feel badly about their neurodevelopmental disorders. It's just unacceptable. And it's almost universal in the context of Wolf-Hirschhorn. And not only is this just a horrible experience, but it actually causes harm. Patients with intellectual disabilities get worse care in the United States, and I think this is true worldwide. They get worse care. And I know this contributed to the death of at least one of our support group members that I know off the top of my head, because physicians caring for this patient ignored serious symptoms, just ignored, blew them off for years, and until she was dying of her problem. And many parents report going to the physician and saying, "I'm having this serious symptom," and the physician will, "Well, who cares?" And so there's a lack of advocacy for the patients on the part of their care providers. We're their caregivers. We're supposed to be their advocates. We're supposed to be caring for them, not dismissing them, diminishing them, and kicking them out of our office. So I think this is probably the number one sort of medical / clinical issue we run into, is just this stigma, and it's really unacceptable. It comes from healthcare as well. In the U.S., we have a huge problem with education and services. We do have public. Federally, you have to have public early intervention, what we call early intervention, which is physical therapy, occupational therapy, speech, and routine assessments of development. From birth to age 2, anybody can be referred to, and they come and do assessment, and then they should provide services if they're needed. However, they're provided through your county. So it depends which county you live in the United States. And you guys have counties here too, right? Or something along those lines. Anyway, so it's a region. It's bigger than a city, but smaller than a state. So it's really variable. So even though they have to do it, it might not always be very good. Some counties are excellent, and you get services every week. And some counties are terrible, and you get monthly services. If you get speech therapy once a month and you have a speech disorder, you're not going to make enough progress. And the other problem is that it's federally mandated until age 2, but they can't go to school, any kind of school services, until they're 3. So you can get a year whole. And in the United States, because we have lots of holes in social services in the United States sometimes. But now in Minnesota, early intervention goes up to age 3, and then you start preschool at age 3 and you get your services. So we don't have a hole in Minnesota, but there are places where there are holes. You can get private services. A lot of insurance won't provide coverage for services like therapies, or only limited amounts. So you can get 5 sessions of physical therapy, which is not enough if you have a neurodevelopmental disorder, because if you have a neurodevelopmental disorder, you probably need weekly therapy forever. So 5 visits is not going to work per year. And some insurances won't cover any kind of therapy. That's just a problem we have in the States. And the out-of-pocket cost is unsupportable for most of our families. And then providers. And we also then, when they're a little bit older, our disability therapies are provided by the schools and physically located at the schools. And it's totally dependent on what school you go to, which is sort of a regional issue in the States. Sometimes it's great, sometimes it's horrible. And then again, the same issues with if you want to get private services for your kiddo when they're in school age. Again, maybe no coverage, maybe minimal coverage, and it's very expensive and it's hard to find somebody. And then, of course, adults, which is just bad. We do have a disability income available for our adults, and most of our Wolf-Hirschhorn patients will be able to get that. But other than that piece, because really they need, living place, they need work if they have a ability for that, supervised activity. And so some places we have great, like in the Twin Cities, where in Minneapolis, where I work, we have good group homes, and we have sheltered workshops, and we have recreational activities for developmentally disabled adults. But if you're in a rural area, nothing. So, and of course, if your family's rural, you're not going to want to send your developmentally disabled young adult to the big city to get their services. So that makes it really, really hard. And of course, this is hugely variable depending where you are in the U.S. too, on top of everything else. So the social challenges are probably, that's the one that I get a lot of feedback from parents. But there are also medical challenges, and I think the biggest one is really provider access. I think I've talked about this a billion times by now. But in the U.S., genetics education is really inadequate for primary care providers. And so sometimes I can't find a primary care provider for my patient. So they don't have a regular doctor who lives close to their house because they're uncomfortable with patients with rare congenital conditions, and they will sometimes just refuse. So there may be, a few primary care providers in their town, and none of them will take a patient with Wolf-Hirschhorn. And then others may accept them into their practice, but don't have time or energy to learn anything about it, so they're not providing good care. And there's something called a medical, in the U.S. we call it medical home, meaning your primary care provider, whether that's a GP, a family medicine doctor, a pediatrician, who will coordinate between all your specialists, make sure your medications are getting refilled, follow up with your school if you need something for your school. And this is really hard for many of my patients for all of these reasons. The other problem is, if you look at the review articles written by Dr. Carey and Dr. Batali and Dr. South about how we should take care of patients with Wolf-Hirschhorn, and kind of my personal opinion, you're going to need multiple, to really do this right, you're going to need multiple subspecialty providers. You need a genetic specialist, you need a neurologist, you need an otolaryngologist, ear, nose, and throat specialist, an eye doctor. You should have a feeding specialist, and the sort of review articles by Dr. Batali suggest a feeding team, so a multi-specialty feeding team, which I think we have like 4 of those in the entire United States, which is an enormous country. And then you need developmental specialists and therapists. You may also need all of these other people. And that works out to 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 12-ish different doctors. Sometimes you can't do that. And of course, we have a huge problem with our rural areas. In our rural areas, sometimes we have no primary care providers. And in the rural areas, if you have one, they're going to be a GP. And GPs do not like congenital disease and will sometimes refuse. And then, of course, specialty care, which we were just talking about, the 12 specialists you need to see, was really just in major metropolitan areas. And I have patients who drive 9 hours to see their specialty team, which is at my center, which is, and of course, they don't get reimbursed for their travel expenses. So this is often insupportable. Growth. Okay, after like stigma, this is the second thing that I talk to families about, and I know we're getting close to the end here. Partially because they're getting beat up by their pediatrician about their feeding, because the pediatrician is attributing the growth to feeding. And yes, our patients struggle to eat, but they won't grow no matter what you do with the feeding, because at baseline they don't grow. And this is really a piece of the stigma that a lot of the parents report to me, is that they're being stigmatized by their pediatrician for not feeding their child because their child isn't growing. And because their child isn't growing, they must not be feeding them properly, which is, that's actually not logical in the context of Wolf-Hirschhorn. And there's, this issue of possible serious underlying GI problems, which would be contributing, which if you're assuming it's all from bad feeding, you'll miss. And no matter what we do, the normal state for someone with Wolf-Hirschhorn is to be very small. That's normal for them. They don't need to be normal for someone who has all of their 4th chromosome. They need to be normal for someone who has part of their 4th chromosome. So we need to, on some level you got to monitor this, and on some level you got to let it go. And this is really just intensely frustrating for parents. And then as far as medical issues, the other big one that comes up is seizures. And one of the big struggles that we've had in the U.S. is with this immunization business, and we addressed it a little bit earlier. And a big problem is because fevers trigger seizures for people with Wolf-Hirschhorn, even if they don't really have a lot of seizures at baseline. And of course, immunizations can cause seizures. And so a lot of my patients have had their initial seizure after a set of immunizations, which makes it, number one, makes it hard to fully immunize them because the parents are scared, legitimately scared to do another set of shots. And then if they get a dismissive response from a provider about that fear, then you suddenly don't have a good relationship with your provider anymore. And then, of course, seizures can be really challenging to manage. In our patients that have significant seizures, many of the parents tell me about switching from one seizure to med, and of course, you got the side effects from the seizure meds, and then some of our patients never completely suppress their seizures, and some patients have had to try the ketogenic diet, and of course, then it's hard to find a provider who's comfortable with your seizure management. And then, so that is also another area that parents express to me as being a big problem. And then there's the risk for status, which is one of our big sources of morbidity and mortality. If I could pick one, that's a big piece. So, and then, of course, this is another big question that I get from parents. I mean, this is the biggest question I get from parents is, what do we do over the lifespan? And of course, we just don't know. Just like all other rare genetic conditions, all the data is cross-sectional, and it's pretty much at diagnosis. So you're like, well, when I, 10 years ago, diagnosed these people with Wolf-Hirschhorn, this is what I saw. And, there's no follow-up. And then also provider access issues. So it's very, very, very hard to find people, even though I'm trained as a pediatrician originally and also as a medical geneticist, I continue to follow my patients lifelong because there are no adult geneticists, basically. I mean, I think there's about 10 in the United States, maybe. And they certainly aren't all comfortable with chromosome conditions. So it's really hard to get. And then, of course, if you need a cardiologist when you're adult, or if you need a gastroenterologist when you're adult, if you need an ear, nose, and throat doctor when you're adult, you may not be able to find one at all that's willing to see somebody with a neurodevelopmental disability. And then behavior. So overall, I get really good reports on behavior with kids with Wolf-Hirschhorn. The first thing everybody says is that their kids are easygoing, affectionate, sociable, playful. And informal assessments, socialization skills exceed language skills and cognitive skills overall. This is a big picture. And I get this story too. They love music, they're outgoing, they love a party. But there are still some impacts from behavior. And there's a couple pieces to this. Anytime somebody has a language problem, you're going to see behavior because of difficulties with just communicating. A lot of patients need assistive communication. And I can't tell you how many times I've literally heard the direct quote, "My child does not like to be ignored," from a family. They'll say blah, blah, and they're like, so much fun and they're interactive, and they do not like to be ignored. And so when parents often report that when they see adverse behaviors, it's because they've been looking away from their child and trying to get something else done because the child really wants to interact. And so although I don't have very many patients that have been reported to hit, if they do, it's attention or communication. And then our higher functioning kids really do seem to have quite a bit of ADHD. So if you get to the point of the kid being, because the kids who don't have much language can't really have formal testing in some of these settings at the sort of to get to the criteria level of ADHD. But the kids who can be tested often meet criteria for ADHD. So there's definitely an attention and a zippiness piece for a lot of the kids of being very zippy and busy. And then, of course, executive dysfunction. And one of the patients that I follow who's really quite high functioning, and he's in high school, boy, does he have executive. So he's, executive dysfunction being like planning, organization, not forgetting your homework, not forgetting your backpack, looking at the teacher when they're talking. He's got his other things. He's socializing with his friends. He's cracking jokes, and he's not paying attention. And so that's a big piece, especially for our higher functioning patients in my experience, is sort of this ADHD / executive dysfunction piece. And then a decent number of my parents report some sort of sleep disruption, although it didn't sound like, it's not, I mean, it can be worse. It's not as bad as some of our other disorders, but certainly disrupted sleep has been a piece reported by a lot of parents. And the other problem is that disrupted sleep is challenging to manage if it's present. And then we do get some stereotypies, especially with the kids with bigger deletions. But you see a lot of these kinds of things. And the teeth grinding, the other ones people notice and doesn't bother them as much. The head banging and teeth grinding are the ones that people really are bothersome, and they can be really challenging. And of course, with behavior, probably the biggest issue again is provider access. We are so limited on our behavioral and psychiatric providers in the U.S. And even if you can find somebody who likes to look at behavior, a lot of them aren't comfortable using medications as needed, and so then you need another provider besides your primary behavioral provider to provide to prescribe medications if they're needed. So you've got to have two people when it's hard enough to find one. And then we have pretty much no access for adults. So most of, at least in Minnesota, in the state of Minnesota, the people who take care of behavioral issues for children will not see anyone over 18. This is true. 2 weeks ago, I spent 5 hours trying to find someone for an adult. It was actually a Fragile X patient. And the adult providers will not see people with neurodevelopmental disabilities. That's not true. There is one practice who will, but they have a 6-month waiting list. So we have essentially, in the state of Minnesota, we have essentially no access for adult patients with neurodevelopmental disabilities and need behavior management. It's a huge problem. And that's actually kind of true overall in the United States, not just in Minnesota. Okay, so summing up, what do patients want? Of course, the caveat here is that I am not actually a parent or a patient. So this is just from what people have said to me. I can't see inside people's brains. Families consistently say they want accurate information, but not doom and gloom. That's a literal quote from many patients, this doom and gloom business of, we want to know what Wolf-Hirschhorn means, but we don't want you to just terrify us and tell us it's going to be horrible. And then many patients expressed appreciation for when their provider admitted they didn't know. Like, well, you have this, and I don't know what it means, so I'm going to have to look it up and get back to you. And just came out and said that instead of trying to make something up. Big important thing. Your person first. So the patient is Lauren, is Joe first with Wolf-Hirschhorn, not Wolf-Hirschhorn first and then Lauren or Joe. And that's really, really big. And then the parents mentioned they wanted room for hope, because a lot of times they're disclosure conversations, and our conversations about Wolf-Hirschhorn are just about how bad this is all the time. And then the other big piece is this is so incredibly variable that we have to respect the differences in the kid, and you have to respect the parent. Oh, and this is kind of stuck in here. So the stigma is really hard to fix. This is a great, so I met this guy last Friday, actually. So positive exposure, this is a guy who used to be a high fashion photographer, so he would do like New York and Milan and photograph like Cindy Crawford and blah, blah, and all those people. And he decided that we needed to look at doing good medical photography. So this is someone with albinism, and he does medical photography that's beautiful instead of just, the person standing with the box in their eyes. And this is sort of a great way of addressing some of our stigma. And he's got a whole bunch of different pieces now to this program. This is just a screenshot from his website, but this is a great, stigma is a problem. I don't know how to fix it, but this is a piece of it for sure. So, and then this is just some resources and family support. Some different places that I found. And then that's what I got. Isn't she beautiful? This is from Star and Rye, which is my favorite blog. So this one right here. So this is, the person who writes this is her mom, and she's a member of our 4P- support group, and it is an incredible blog about the experience of parenting a child with different development. So.
Thank you.
I almost made it.